Grandrounds this morning. Appreciate everybody being here. I have the privilege of introducing the speaker this morning. So this is Dr. Sumana Nagareddy. She joined our group in 2015. She completed her internal medicine residency at the University of Alabama at Birmingham, and then she completed her hematology and oncology fellowship at the University of Mississippi in Jackson. She's well known for her strong work ethic and her infectious smile, and she takes excellent care of her patients and our patients when she's covering on the weekends. So let's give her a warm welcome this morning as she's going to talk to us about immuno-oncology and give us an update this morning.
Thank you, Dr. Graham. So I try to put this lecture just for internal medicine residents and physicians. So I'm not going into details of all the studies and like what's the benefit, what's the overall survival. So it's not intended for any of like our hem-onc colleagues. So it's like basics of immuno-oncology. So in the past, for any cancer treatment, we used to say just do surgery, radiation, or like chemotherapy. We didn't have other options. So everybody got this like feeling chemo is like harsh and it's rough. But we have new approaches coming in oncology, and it's very like fastly evolving field where you have a lot of other options, not just the conventional options. So we'll go through basics of immuno-oncology today. So today's objectives are, we'll learn about basics, then how these drugs are incorporated into our guidelines, and how we assess the response criteria, and what are the major side effects and how we deal with them, because the side effects of immunotherapy are like quite different from the regular conventional chemotherapy. So if you look at immunotherapy, we have like different approaches. It's not like one drug, like one type. So it's actually three basic approaches. One is like antibody approach where so we have been having this antibody approach for a long time, like all monoclonal antibodies. They're kind of immunotherapy also. Suppose you take rituximab, you take any MABs, those are all antibodies. So it's kind of part of immunotherapy. Or T-cell mediated, which is more evolving now, and then a vaccine approach, which is also evolving a lot. So if you see here, like it's just antibodies directed against either tumor cells or any other cells. Here, the T cells affecting the T cell affecting the cancer cell, and this is the vaccine approach. So to know about the immunotherapy, you need to know basics of like our immune system. So we have two types of immunity. One is innate immunity and the adaptive immunity. So when you get attacked by a pathogen, your cells, like the innate immunity, it's already there and it try to attack. So there are different kinds of cell, macrophages, neutrophils, NK cell, natural killer cell, and our antigen presenting cell. So out of these four, these three are like mainly attacking the pathogen, but its job is trying to affect the adaptive immunity, so that you're going to stimulate this B cell and also T cell, so that it in turns affect the pathogen. So when the pathogen is present, it can be an infection, it can be a tumor, anything like foreign to us. So your antigen presenting cell affects the B cell and T cell. It's a B cell, it's going to produce antibodies. If it's a T cell, it produces different cytokines which attacks the pathogen. So basically, innate immunity is important, but also you need adaptive immunity to affect any pathogen and cancer cell. So it's a little bit busy slide, but to know basically about how our drugs work, you need to know what are the receptors on the cell so that we can see how these drugs work. Suppose if it's a tumor and it's going to secrete some antibodies, and then this kind of stimulates our antigen presenting cell, and then antigen presenting cell is going to present this antigen to this CD8 cell. This is inactive cell right now. So whenever this antigen is coming, it gets activated. If you see this cell, it's going to produce lot of cytokines, interleukins, granzymes, and CTLA4. So out of these, interleukins, interferons, all these are trying to kill the tumor, but CTLA4, it's a kind of a brake on our immune system. So if you don't have a brake, you're going to attack your own cells sometimes. So if you get stimulated, you're going to get continuous stimulation and then autoimmune effects like inflammation of every organ. So you need to have some physiological breaks so that it's not going to continuously affect our own cells, but it just affects the tumor cells. So this is a physiological break up here. So just keep this picture in the mind, and when we go to the drugs, it helps. So the major hallmark of this cancers is it's try to avoid the immune system. So basically, even though you're trying to attack, you just like step back and ignore the immunity so that you will be like not attacked by the immunity, then you can do your job like very easily. So how does this tumor avoids our immune system? It can be different ways. One of them is it alters its specific antigen. If we go back to our picture, how the antigen is present, it may not produce that antigen, or there is alteration so that antigen presenting cell cannot recognize that antigen. So you're trying to hide. It's like maybe I'll say terrorism in US where like you're trying to hide, like you really cannot recognize. It's like it's in the like population. So the tumor cell is like that. It's going to hide or change its antigens or alter its antigens or lost its antigens so that your immune system is not recognizing your tumor cell. Sometimes it just promotes immune tolerant microenvironment, and also these are the two PD-L1 and PD-1 receptors. I'll tell about this in a minute. So these are kind of physiological breaks too. If you have more of these, that means you're going to block your immune system attacking your tumor cell. And this diagram is very important of like out of all the slides that I have, this is one of the most important one. So if you look at this slide, initially this is normal tissue. And whenever you have different carcinogens, it can be anything, radiation, viral infections, inflammations, or like genetic mutations, any of these triggers making this normal tissue turn into abnormal cell. This is the cancer cell. So if you see up here, these cancer cells have a lot of antigens so that your immune system can recognize these cells and try to eliminate them. So it has like different kinds of receptors where your immune system can recognize them and trying to attack these cells. So if you can kill all of those, actually you will never present with cancer at all. But unfortunately, sometimes what happens is, as I said, it's going to lose its receptors, or it's going to produce an environment where your immune system is not able to recognize these cells. By doing all these, like you will get resistant cells where it's going to grow. So if you see these two cells, this is normal cell. This is a cancer cell, but it's still producing some antigen so that like your immune system can attack this. But these two cells doesn't have any antigens or receptors, so it's kind of avoiding the immunity and trying to stick there for a long time, even though your immune cells are there, but it's just not recognizing them. So if it's not recognizing them, it's not going to attack them. So they kind of proliferate more and more and more. So once the normal cell turn into the cancerous tissue, if you're able to control it by all these immune adaptive and innate immunity, you're going to eliminate this. But once you lose that antigen recognition, once these abnormal, poorly differentiated cells are there, it's going to escape that immune checkpoint where like you're going to proliferate more and more and more, and then now your immune system is not going to recognize those cells. So our job is trying to find some way so that we can recognize them and attack them. So that's where this immuno-oncology is coming into the picture. So basically, so far, we have innate and adaptive immunity to control the tumor, but sometimes the tumor gets more tricky and smart so that it escapes the immune recognition so that it cannot be targeted by your immune system. And we are trying to treat them with different immunotherapy agents so that it can be recognized and attacked by like your immune system. So basically these drugs are not attacking the tumor by itself. It's making your immune system most effective so that it goes and attacks your tumor cell. So there are different kinds of immunotherapy. I'll briefly go through a couple of them, but I'll concentrate on immune checkpoint blockage. So we have these cytokines for a long time. So for melanoma and renal cell cancer, we have been using different kind of interferons, interleukins to treat adjuvantly or metastatic in the past. So basically we started with cytokines. Then the recent approaches are all these. I want to go a little bit detail into adaptive cell transfer due to recent approval of one of the drug for our ALL. So we'll go a little bit detail into this drug. And vaccination strategy, we have it for a long time too. Even like suppose, let's take BCG. So for bladder cancer, if it's non-invasive, after resection, urologist will inject so that these bacteria will produce some immune reaction up there so that the whatever tumor cells there, they're going to get attacked by the immune system and then keep the tumor under control. So basically I'm going to go through this, but we'll briefly go through this too. So I told you about interferons, interleukins, vaccines, and even this is Revlimid, lenalidomide, that's we use for multiple myeloma commonly. It affects our, at the cellular level, it affects our immune system so that your myeloma cells is like under control. So this still considered as immunotherapy too. So this is little bit that I want to go into. Adaptive cellular therapy or CAR T cells. So CAR T cells are, let me show you the picture first. So we collect patients' white blood cells and then we isolate some active T cells and then they are genetically modified with a gene so that like it recognizes your tumor cell more. And then you grow most of these cells and re-inject into the patient. So when this is re-injected, these cells goes and attacks specifically the tumor cells that you're trying to recognize. So when your tumor cell is trying to be like evasive and trying to hide, these cells are going to find them and attack them. So there is a new approval just happened last month. I don't know how to pronounce this, but I'm thinking Kymriah or Kymriah. So this is a new approval that just happened last month for ALL. So this is kind of gene modified therapy or where like patient directed therapy. It's not for all. It's just like not drug that you have a shelf that you're going to give it to the patient. It's specifically for that patient. You're trying to take their T cells and then trying to make them more smart so that they can kind of find the tumor cells which are hiding everywhere and attack. So it's all over like CBS and NPR for the last 2-3 weeks. It's genetically modified for that person. So we are getting more attention of this. There are only 3 or 4 centers in United States who can do that right now. So the drug companies are fastly moving so that you have to have a center where you can actually send the cells and they can genetically modify the cells and re-inject it to you. So it's going to take a lot of effort and money, but we are having great results. So far, this is the only drug approved for ALL. It just happened for mostly pediatric ALLs, but up to 25 years resistant to all other previous treatment, you can use it. So this is going to be the future of our oncology, where we say like CTCA saying we treat the patients like so personally just for you. So this is what we are talking about. But it comes with a lot of risk. It's not that easy. It's just like interferons, interleukins. You have to admit the patients and put them in ICU, and you have to look for a lot of side effects. So what's going to happen is when you are stimulating, sometimes these cells going to cause cytokine release syndrome and really cause mortality. There is up to at least 5% mortality or sometimes 30% mortality with these early stage trials with the new drugs with CAR T cells. So you have to be very tricky. If you don't have time, it's hard to, expect your bet on this one, because it takes time. You have to collect the cells, send it to the facility, they have to regenerate it and send it back, and it has to attack. So if it's emergency, it doesn't work. But if you're planning, if you have few weeks, it really works. But you have to be very careful, and it has to be done in a facility where they have enough experience. So far, the University of Pittsburgh is doing it. There are like 4 or 5 centers in US that they are doing it. So we didn't do any patients, we didn't treat anybody with CAR T cells here yet. So you can expect lot of infections, acute kidney injury, hypoxia, and mainly cytokine release syndrome is a major side effect. So let's talk about the immune system again. It's similar to what we saw before. So you have this is the tumor bed, and then it's going to release some antigens, and your antigens are recognized by your dendritic cell, and then it's going to activate your T cells, and then the T cells are going to invade the tumor bed and kill it. So this is the basic concept. And then let's look at this, where like at the cellular level, how does it going to work? So all the ones up in green, those are stimulative receptors. All the ones in red, they're blocking receptors. So if you have too much of this, you're going to attack this tumor cell, but sometimes you may attack your own cell too. So you need to have some of the breaks so that you're not attacking every cell, you're just attacking the foreign cell. So in the body, these two are in equilibrium or balance, so that you're attacking the tumor cell, but you're not attacking the normal cell. But sometimes these physiological breaks are like, these are kind of not helping us, because your tumor cells kind of thinking your T cells are thinking tumor cells are your own cells, because you're blocking their, these two receptors are making your immunity not to recognize them. So we have lot of receptors where we can play a little bit and then try to find more drugs. So this is another diagram showing where we are right now and what all are options for the future. So right now there are a lot of drugs approved, anti-PD-1, PD-L1 and CTLA. But there is a lot of trials going on with anti-LAG3, anti-OX40, and then I didn't put IDO up here, but there are a lot of immune checkpoint areas where we can develop a lot of drugs. But for now, we are concentrating on this because this is where a lot of studies were done and drugs were approved. So here, it's the same again. It's your T cell and your dendritic cell. So whenever it's going to present antigen to your T cell, it has to be activated but you have your brake here again. So it's going to stop that signal so that your T cell stays suppressed. It's not going to be activated until this brake is gone. So this is a physiological brake. Even though you have some stimulatory factors, this is an inhibitory factor. So whenever you have this, the T cell is going to be suppressed. So next, let's look at the same picture again. So when we block this CTLA with an antibody, you're taking breaks. So you're taking your leg off the brake so that your immune system is like in full attack, and your T cell is going to be activated and it affects the tumor cell. So basically, we need this, otherwise you will develop a lot of autoimmune disorders. But in tumor cells, we are trying to block this so that your T cell, which is suppressed, is going to be activated and recognize your tumor cell and attack it. And same story with the PD-L1. So this is your PD-1 and PD-L1. PD-1 is on the T cell and the PD-L1 is on the tumor cell. So it's a physiological brake like CTLA4. So what you're doing is, even though you have a stimulatory mechanism, your T cell going to be suppressed as long as you have these two liganded to each other. So what we are doing is, we can make antibodies to both PD-1 and PD-L1 so that you're taking these brakes off, and then you're going to make this suppressed T cell to activated T cell so that it's going to attack the tumor. So basically, so far what we discussed is, you have natural activating mechanism and inhibitory mechanism. Either you have to activate your activating immunity or inhibit your inhibiting immunity, so that at the end of the day, you're trying to recognize your tumor cell and trying to kill it. So I'm not going into in detail about all the drugs. It's just not up to date, but you can see how many, these are only a few drugs, but how many diseases like it can control or treat. So we started this immunotherapy basically with melanoma. So CTLA4 antibody, which is ipilimumab, which is Yervoy, is the first drug which is approved here for melanoma. Slowly we started knowing more about PD-1, PD-L1, so we have more drugs. So this is PD-1 inhibitors, and this is a PD-L1. But this is where we started. So if you can see the list, and the list is going to grow. So we have, it's approved in melanoma, in lung cancers, in head and neck cancers, lymphomas wise, mostly Hodgkin's lymphoma, you name it, it's going to be there all over. Like down the road, 2 or 3 years from now, I think it may be where like we might forget some of the chemo drugs. That's where we are going. So one thing that I want you to know is, in the past, it's all second line, but now few of the drugs are first line. If you see pembrolizumab, which is a PD-1 inhibitor, and it's called Keytruda, and it's approved as a first line. So you can use them, like if you have a stage 4 cancer, depending on their PD-L1 status, you can use them as upfront. Or there is a new study where you can combine with the chemo to get more results. So if you have a strong fit patients, you're going to put your odds to use everything so that you can control them like at the max from all sides. Like you can use your chemo, you can use immunotherapy. So it's not like, so far, nivolumab didn't get into the first line in any drugs yet, but Keytruda, which is pembrolizumab, is a little bit ahead of the game, even though this came first, and it's approved in lung cancer as a first-line agent. So you see it's melanoma, non-small cell lung cancer, renal cell, head and neck, Hodgkin's, bladder cancer, Merkel cell. And then the reason why it's not very effective in others, it's just the theory, it's not proven yet. The more mutation burden you have, the more active the drugs are, because you need to recognize, your immune system need to recognize those tumor cells. If your tumor is like it's like hibernating, not active, and it doesn't have a lot of mutations, your immune system is not going to recognize them, so it doesn't attack it. So the more tumor burden you have, the more effective the immunotherapy will be. That's the theory, and we have to go in detail why, like where it is and how we make these tumor cells more antigenic so that we can recognize them. But melanoma and renal cell are like, you have a lot of mutations in there, even GBMs, where like you can try to use these drugs. And a lot of work is going on with GBMs, but so far it's not approved yet. Other thing that I want you all to know is MSI high tumors. Generally in the past, when the drugs got approved, like suppose anthracyclines approved for breast cancer, or like this drug is approved for this specific histology, or nivolumab is approved for lung cancer. But recently, for the first time in FDA history, it's not histology. If you have any tumor with a solid tumor with high MSI, you can use this immunotherapy. So that means if they have high mutation, kind of it goes in favor of like high mutation burden. So if you have high MSI high, that means this immunotherapy is going to be effective. So now what we are doing is, if you have a solid tumor, you're already 2, 3, third line, fourth line, and you don't know what to do next, we can check that, and if you get lucky, you can use immunotherapy. It's approved for any solid tumor with MSI high. So far we just discussed about how it works, what drugs available, what cancers we are using, but I just want to give a little bit of attention to what is the response, how we assess the response. Generally for chemotherapy, we call it as RECIST criteria. Like once you give the treatment for a few cycles, you get a scan and see, is it the same or 50% decrease, is it progressive? But immunotherapy, it's going to be a little bit tricky. So let's look at this. This is the patient, and if I don't know if you can appreciate, there are small like tumors up there. But once you treat it with immunotherapy, if you do a scan, it scares you. It's all big, so it's not working. It's getting worse. But it's because all the tumor cells are coming, all the T cells are coming and attacking the tumor cell. So it appears bigger due to that inflammation and attack by your T cells and B cells. But if you give some time and be patient, this is the end result. So there is a pseudo progression with immunotherapy. So that's one thing we all need to recognize, that the entity of pseudoprogression is not common with cytotoxic chemo, but immunotherapy, that's one thing you just have to like keep in mind because of the inflammatory reaction that your T cells are going to do to tumor cell. So let's talk about side effects. The common side effects from chemotherapy is fatigue, nausea, vomiting, hair loss, bone marrow toxicity. You may not get those classic side effects from immune therapy. Any itis, you name it, it can be any itis. So hypophysitis, thyroiditis, hepatitis, maybe I should say dermatitis, pancreatitis, colitis, arthritis, adrenal insufficiency, pneumonitis. So it can attack any cells, but commonly the thing we see is colitis. That's more common than any. But I have seen bad pneumonitis and adrenal insufficiency too. At the beginning, I didn't pay attention why my patient is like hyperkalemic, hyponatremic, he's on immunotherapy, but I was just thinking of what's causing it, but I didn't realize for my first patient when I treated, he had adrenal insufficiency from the immunotherapy that I was doing. So it can cause any itis. So you have to be vigilant about the side effects. If you don't know it, actually patient can die. So we always tell the patient, if you have new loose stools and you cannot control, new hypoxia, shortness of breath, like call us. Pneumonitis is more life-threatening than anything. So at the beginning, when we started using immunotherapy in the community, the scary thing was like patient dying with this pneumonitis before you recognize them. But if you educate your patients well enough about all the side effects, I think it's a safe drug, but you just have to be vigilant about the side effects. So it's a table showing, again, the side effects. It's less common, but more life-threatening, the pneumonitis. And the colitis is more common, but it's mostly manageable. And hepatitis, any endocrinopathies, pancreatitis. I have seen one patient that I didn't treat, but I follow. He developed diabetes after he started immunotherapy at an institution in Nashville. So he's in a trial for lung cancer, and he started having this uncontrolled blood sugars. And finally, they determined it's a side effect from the drug causing autoimmune pancreatitis, and also he developed diabetes mellitus from it. It can cause encephalitis. I never saw this one, but anywhere you have these symptoms on the patient who is getting immunotherapy, we just have to be cautious. So what do we do when you get these toxicities from the drugs? Depending on the grade, if it's grade 1, just we support them. But grade 2, most of them are like either grade 2 or 3. So mostly grade 2. You do the oral steroids, but you're trying to, suppress that immunity that's working. So it's a balance issue where you're doing too much immunosuppression again, then your tumor is going to be unrecognized and then it's going to grow. But immunotherapy is not going to work if you use high-dose steroids, but you have to make sure patient is safe enough so that acute inflammation is gone, then you can restart the immunotherapy again. But whenever you're doing steroids, you're going backwards a little bit. But it's okay because you need to control the side effects for that minute, otherwise it can be life-threatening. If it's grade 3, we have used IV steroids and also immunosuppressive agents. I know Dr. Graham has multiple patients where he experienced like colitis in the patients, and then he even has to give infliximab for colitis. So it can be life-threatening sometimes. But basically, step back, hold the treatment some time, give steroids or immunosuppressive treatment. So that's what we do with side effects. So about these immune-related events, basically, the toxicities are different, so you just have to know how they can present. It can be fatal, especially the pneumonitis one, and then we manage with steroids. And then there is no data to do like dose reductions, but I did in 1 or 2 patients where I don't know what to do because every time I do the treatment, she developed fever, got admitted with kind of pneumonitis, and she didn't want chemo, so I had to try, but generally dose reductions are not recommended. So let's look at where we are going after knowing there is immunotherapy drugs we can use in different cancers, but there are a lot of unanswered questions. Suppose, like tumor types, we are now like little bit ahead of the game, like which types we can use. The more tumor burden, the more mutation burden you have, it's going to work better. And we kind of knowing the immune-related toxicities and then how we treat them, and we know what's the response criteria. It can be pseudo-progression. So we know this little bit. But the basic thing is, how do we combine them? What comes first? What comes next? Is it before chemo, after chemo? Can we combine 2 immunotherapies? Or what is the sequence of them? Suppose in melanoma, there's a big question in the beginning. Do you use your Yervoy first or nivolumab first? Or can we combine them? So it's really like now how to sequence them and combine them and use them more efficiently is the big question for the clinical trials. And which are the patient going to be having best results when you do it is another question. Suppose let me tell you this. For lung cancer, it's approved first line, but it's approved only in patients with PD-L1, which is a receptor more than 50%. So theoretically, the more percentage you have, the immune cells are going to recognize them and attack them. So it's only approved for patients with high PD-L1. But what happened to the patients who are not having, so which are the biomarkers to see how it's going to work? So we are still working on this. And then how long we treat it. So far, we don't know. We are thinking it's long term, but the theory is when you're boosting your immunity, you're going to create some memory cells. So when you create those memory cells, even if you stop immunotherapy, it's going to work. So now some institutions are stopping immunotherapy at 2 years for melanoma and still they are having good results. So down the road, maybe in a year or two, we will have mature data for enough duration and then hold on the treatment if the patient is comfortable and then see if you can still keep the tumor cell under control with your memory cells. So that's one thing that we really don't know the answer to yet. So this is a busy slide, but we talked about it's like one drug for everyone, every tumor, whatever the age is. So it's like one drug for all the tumors. But which patients get most benefit? How do you choose the drugs? It's still debatable and still like we don't have good data yet. There's a lot of research going on. So basically, the more inflamed your tumor is, the more antigens it can produce, your immune system is going to find them and attack them, or your immunotherapy is going to work on them the best. But if you see this, if it's non-inflamed, then you're trying to look for other options to support your immunotherapy. The anti-PD-L1 and PD-1 is going to be like the backbone. Still, it's there, but we are trying to add IDO inhibitors, chemoradiation and target treatments, CAR T cells, some vaccines, and then anti-OX40. So there is a lot of things going on. Still, we don't know the answer to, but it's kind of personalized treatment down the road where it's not like everybody with cancer get immunotherapy, but depending on what kind of tumor they have, how much antigenic the tumor is, what kind of immunotherapy we can add to the basic anti-PD-1, PD-L1. So there is a lot of research with IDO inhibitors and CAR T cells. These are the two drugs which are going to be approved more and more in the near future. So again, it's the same picture showing we started with CTLA4 and PD-1, PD-L1. These are physiological breaks, and we produce drugs to counteract this. Now your immunity is kind of recognizing the tumor cell and killing it. These are the first generation. Then there are a lot of studies with LAG3, OX40, and then we have IDO inhibitor. So we are going to expand this immune therapy from here to like more and more drugs. And at UAB and some other institutions, there are a lot of other vaccine kind of strategies where you can inject the drug to the tumor like melanomas, and you will have good response too. So there are a lot of clinical trials. So we are encouraging all our patients, if you're out of your options for like metastatic disease and young patients, good performance, then they should be enrolled in a clinical trial to explore more options for it. It's next to the next generation sequencing and target treatments. That's going to be basic too, but immunotherapy is going to be more evolving and more options available, because if you do an NGS, you may not have a target that you can treat with. So target therapy is there, chemotherapy is there. We are not avoiding them, but immunotherapy is going to be the future for the next generation. So this is actually my last slide. So at the end of the day, you get $50 million or like $5 million bill. So we really don't know what's the cost of it, but it's really interesting how much improvement we had in the last 2-3 years compared to last 20 years. So it was kind of a dormant for so long. All of a sudden, first we got this ipilimumab, then like one after other, we're trying to find more and more and more drugs that can attack the different tumor types. Now you have the drugs, you're just exploring them in all the tissue types that you can. And now once it's approved in that tissue type, go to the front line and see can we use them in the front line or combine with the other immunotherapies to get the best response. So I left some time for the questions.
When you have a patient who's had complications, say with ipilimumab and colitis, and you have to use, suppose they've got grade 2 or higher complications, and you have to use an immune suppressive to calm things down, does that affect survival? Is there data that shows whether that affects survival?
We don't have data for it, but theoretically it does. Generally, we don't want to use immunotherapy if they're on like prednisone more than like 5 or 10. So you want to cut down your steroids as much as possible, then restart your immunotherapy. But we are going to have some data by next year, like the more patients we enroll them with the side effects and immunosuppressive, how much. But theoretically, it does affect your effect of immunotherapy.
And what's the incidence of severe side effects?
So pneumonitis is rare, but it's life-threatening. So we kind of educate the patient more on pneumonitis. It's up to 10%, but colitis, low grade can be up to sometimes 30%. But high grade, grade 3, or like where you need to use immunosuppressive, need admission is up to like 5% or less. What do you think, Dr. Graham, in your experience? You had more colitis patients.
So it, depending on the drug, the bad guy and the
It's
good news
EP is, yeah.
The bad guy is the ipilimumab, and the bad strategy was 10 milligrams per kilogram, which was approved in adjuvant melanoma. So a few weeks ago at ESMO was a study that looked at nivolumab, and it clearly beat ipilimumab, and the rates of colitis are significantly less. But with the high dose ipilimumab, it's in the 10-15% range, some type of colitis. But with the nivolumab, you're probably about 5% or less. So the good news is you're not going to see us using a lot of ipilimumab, but when you do, the dosages are anywhere from 1 milligram per kilogram to 3 milligrams per kilogram, which makes a huge difference. So we learned kind of the hard way in adjuvant melanoma about these effects. But the good news is pembrolizumab, nivolumab, atezolizumab, much more manageable in terms of the colitis. But still, you have to treat all of them like they are high-dose ipilimumab, because if you have that 5% patient, it can be rough. We shared the patient one dose in less than 3 weeks, grade 3, in the hospital. I'm afraid we might lose the pulse, but doing okay.
So far for melanomas, until we had this new update from ESMO, EP was the only drug, and unfortunately it's a high dose. So in adjuvant setting, you have 30-year-old, they get their surgery, but you're worried about relapse. You hate to say, I don't have any options and just like let it come back. So you want to try, but the drug is like a beast. It's high-dose ipilimumab, where you can kill the patient with the highest dose, but we have been waiting for this results for almost a couple of years, and luckily now, as Dr. Graham said, low-dose EP is as equal as high dose, so the risk of colitis are much lower. But better than that, PD-1 inhibitors and PD-L1 inhibitors are more efficient than CTLA-4 in adjuvant setting in melanoma. So we are not going to use high dose EP, so you may not see that high grade colitis anymore. But there is a risk, so patient has to call us if there are loose stools. They cannot just ignore it, because they're going to get dehydrated. If it's pneumonitis, actually patients can die within a day or two if you ignore them. So you just have to step back and use steroids and control that overactive immune system, and then let it control it, and then restart your immunotherapy.
Other questions? Go ahead, PW.
Interested in the pathology, you said two things that sound like they're important. And one of them for the lung cancer patients is knowing whether or not they're PD-L1 positive or not. How do you determine that? The other thing you said that I thought was interesting is trying to know whether or not there are T cells in the tumor periphery.
So,
Is that something you routinely look for?
So about the first question, we now for every lung cancer stage 4, like we are asking them to asking the pathology to run PD-L1 staining. So if it's more than 50%, you have this drug approved upfront. If it's negative, then we are going for conventional chemo. Whenever it's not working, you can use the second line drug irrespective of your PD-L1 status. Even like 1%, it's going to, I think, work, but the more the percentage you have, theoretically, it's going to work more. So far for the first line, if it's more than 50%, we use it and we request the pathology to run this on everyone was stage 4 lung. It's only for lung so far, but as the time goes, it may be for other histologies when we have good data that, depending on the PD-L1, you can direct your therapy. I think the main reason so far we couldn't really figure out why nivolumab failed as a frontline setting compared to pembrolizumab. Both are same kind of drugs, it's different companies. Pembro got a little bit smart, and then the drug company used the PD-L1 as a marker, and it used the first line drug only for patients with high PD-L1. And Nivo they used it in everyone. They kind of lost the game in that one. But I think there is a lot more that we don't know, just not the PD-L1. But so far for lung cancer, we can do the PD-L1 and we can order from tissue sample. About the second question about the T cell, we have known if you have tumor infiltrating T cells, like you're going to have some benefit. Even in melanoma and like in colon cancers, the more T cells you have, so we can, it's not general for a pathology to say like TILs, tumor infiltrating lymphocytes, how many are there, but if they tell there is TILs, which is tumor infiltrating lymphocytes, your body is trying to attack the tumor cell. If you have high TILs, there's a good role of immunotherapy, you're going to boost them out. So I had one patient where I tried to approve immunotherapy for a patient with high TILs, but it didn't. But in theory, you can use immunotherapy in a patient where like there is high TILs, which is tumor infiltrating lymphocytes. It's not generally done by pathology. They can mention that, but mostly in melanoma, they mention how many like TILs they see whether TILs is there or not.
I have a question on the CAR T therapy.
Mm-hmm.
Those T cells that are pulled out and are re-engineered, is it an antigen that you're looking in the cancer cell that they're pulling out, and how do they know
So
the sequence to develop it again?
So suppose the one that we got approved is for ALL, so that is directed again as CD19. So you are trying to make the T cell recognize all the CD19 cells only. So it's a directed therapy for specific cancer. It's not for like generalized. So suppose you're attacking ALL cell, the B cell ALL with CD19, you're going to like put the gene so that your T cell are going to recognize the only CD19 cells wherever they are. So that's why it's more specific for the CD19 or like CD20 or T cells. Like you're trying to find more specific cluster differentiation to recognize. It's not there for solid tumors yet because you need some kind of marker to find so that you can genetically engineer your T cells so that it can recognize that marker. So they're trying to put a gene so that the T cells kind of recognize the CD19 cells. So yes, they have to find an antigen, and if the tumor like getting smart and doesn't have any antigens on it, that's when we are going to have more trouble. Non-inflamed tumor, less mutation burden tumor, that's when there is no way. So that's why when you don't have a receptor, when you don't have any mechanism to find the tumor cell, you're trying to genetically engineer and make this T cell more smarter to find a specific antigen and recognize them. But if the tumor is not expressing any antigen, it's hard to find it and attack it.
Ibrahim?
You made mention that some of the tumors can be smart and not express any markers. How common is it to start a treatment whereby you have, let's say, PD-L1, start a treatment, and later on the tumor will kind of change and not express those markers?
So for now, we are not like following a PD-L1 status, like, whether it's expressing or not. It's not like a tumor marker where you guide your treatment depending on it. So if you have high PD-L1, technically it's going to work. And if it's not working, that's when you go to second line agents. But irrespective of your PD-L1 status, you use them as second line. And for now, we have no way which are the patients going to respond the best or not, because you don't have any marker to guide your treatment. So it's just like conventional therapy now, where like you kind of do the treatment and expect the results. And if it's not working, then initially it may be pseudo-progression, but if it's not working, you have to move on. It's not like it's completely a game changer where it's going to cure it or control it. Still, we are not there yet. And we have no marker to guide our treatment or change our treatment depending on certain marker. But it's just, I think we are trying to find more of those to see how we can identify the specific patient who gets the most benefit.